Respected chairpersons and dear colleagues, the topic allotted to me is LDL cholesterol not at goal with statin, what drug to choose. So we'll start with this case. We have Mr. DM, who is 47 years old gentleman. He had no family history, non-obese, non-hypertensive, non-diabetic, regular exerciser, no history of addiction. He had a past history of coronary artery disease and he underwent percutaneous coronary intervention with placement of a stent around 6 years ago. And he was taking regular medications including dual antiplatelets and beta blockers and 40 milligram dose of rosuvastatin. He presented to us with history of prolonged chest pain. There were significant ischemic changes on ECG. He was hypotensive. Coronary angiography showed significant LED occlusion. Labs showed significantly increased LDL cholesterol despite he was on 40 milligram rosuvastatin. So immediately intervention was done, and post intervention he remained stable, and then he was discharged on dual antiplatelet, beta blockers, rosuvastatin 20 plus 10 milligram of ezetimibe. Again at 6 weeks on follow-up visit, LDL was repeated and it was 110, significantly higher than the desired target of around less than 70 or maybe less than 55 as per the current guidelines. So at this point of time, he was started on PCSK9 inhibitor, evidencebased, 140 milligram every 2 weeks, and again a follow-up later at 6 months showed LDL of around 30 to 44 milligram per deciliter. So this was just a case to highlight how new drugs have come in the management of dyslipidemia, and especially for secondary prevention, the roles are there. We have got enough data now. So if we see the role of LDL cholesterol and the duration, so once the cumulative LDL exposure threshold has been exceeded, so we can see once the threshold is increased, there is exponential rise in the total plaque burden, and the incidence of MI appears to double with each increasing decade to exposure to the same plasma level of LDL. Even if the LDL cholesterol level remains the same with the duration of time for each 10 years, the incidence of acute coronary events increases by 2 times. So both, not only the magnitude but also the duration of exposure to the increased cholesterol is important, and the LDL cholesterol as well as the duration of increased LDL cholesterol beyond the threshold determines the total plaque burden, and ultimately it leads to development of acute coronary events. The risk of MI doubles for every 1250 incremental increase in the plaque burden, that is milligram years. So if we want to reduce the risk of acute coronary events, we have to not only reduce the plaque burden, we have to not only reduce the LDL levels but also to initiate the therapy early. The aim should be to start early and to start aggressive. The evidence-based guidelines, both American as well as European guidelines, they recommend that stringent targets should be endorsed, and if the patient has got clinical atherosclerotic cardiovascular disease, the American guidelines, 2018 guidelines, they suggest that LDL should be reduced by more than 50%. For very high risk ASCVD patients or established ASCVD patients, the target is less than 70 milligram per deciliter. The European guidelines for high CV risk is same, that is less than 70 milligram per deciliter, but they suggest that if a patient has got very high CV risk or established coronary artery disease, then the target should be less than 55 milligram per deciliter. And both guidelines, they are on the same platform, that they suggest that from the baseline at least more than or equal to 50% of LDL cholesterol reduction is desirable. But in the real world, if we see the results from the Da Vinci study, so only 1/3 of the patients, they are able to achieve their risk-based goal. And if we talk about the established ASCVD patients, only 18% of the patients, they reach the risk-based goal. There are multiple reasons